I'm happy to have the opportunity to share with you the development and the first experiences with the Stepstones project. Stepstones stands for Swedish Transition Effects Project, supporting teenagers with chronic medical condition. And as you all know, transition programs are complex interventions. And complex interventions are characterized by a number of components that are interacting independently or interdependently, and it is seldomly known which particular ingredient is the active ingredient of the intervention. Complex intervention require a specific approach in terms of investigating this. And we relied on the Medical Research Council framework that was developed several years ago. And it is indicated in this framework that before starting research on the effectiveness of the study, you need to do some preparatory work. And this is indeed what we did. We did several qualitative studies, interview studies and focus groups with young persons with a chronic condition, with their parents before and after the transfer to adult care. And doing so, we learned a lot about their needs and what is needed to build in a transition program. Once that we had done these preparatory studies, we compiled them together and started the process of intervention mapping. Intervention mapping is a methodology that helps you to develop complex interventions with the aim of promoting health. And this is actually how the framework of this intervention mapping looks like, specifically for the Stepstones project. You start at the far right of this slide, the health outcomes. Based on the preparatory studies, we knew that there was a reduced well-being, a reduced biopsychosocial functioning, and an increased healthcare utilization. And based on that, you can look at what are the health problems in this population. When you have identified these health problems, you identify behavioral factors and environmental factors that play a role in the health problems. And then finally, you go to the personal determinants for these behavioral and environmental factors. Once that you have done this, you have a clear view on where to intervene on. It is indeed on the determinants that you have to focus with your interventions. And you know, when you're intervening on these determinants, you're kind of flipping the model, because on these interventions, if you improve them, they have an impact on the behavioral and environmental factors. On its turn, the health problem is facilitated or is improved, and then the health outcome. When we did this intervention mapping study, we ended up with the following intervention. In fact, the Stepstones intervention comprises 8 different components, and we deliver them in 5 steps. The different components, as you can see here, are the transition coordinator, the written person-centered transition plan, information and education, availability by telephone and email, information about and contact with the adult clinic, guidance of the parents, meeting with peers, and the transfer to the adult care. As I said, we delivered this in 5 steps. A first meeting with the transition coordinator, a second meeting with the transition coordinator. The third step is an information day for adolescents and their parents, where they can meet their peers. Then a third visit with the transition coordinator, and then finally the actual transfer to adult care. An underlying principle, which you all are familiar with, is the heads. And indeed, all the communications and all the interventions during the meetings are based on the heads health interview. The question then is, what is the outcome of the Stepstones project? Here you have to go back to the logic model. And if you see that the ultimate outcomes are well-being, psychosocial, biopsychosocial functioning and healthcare utilization, then you could think we take these as the main outcomes of our study. However, the problem here is that these are rather distal outcomes. If you want to investigate this, you need to look for more proximal outcomes. And that's the reason why we choose empowerment as the proximal outcome of our study, also the primary endpoint of the trial. Because we know from literature that empowerment is indirectly influencing the health outcomes of the patients. Then you can wonder, how can you measure empowerment? Well, for that reason we developed the GYPS. GYPS stands for Gothenburg Young Person Empowerment Scale. And the validity and reliability has been investigated, and further studies on the psychometric aspects are in progress. There are different components that we wanted to investigate. And first is the effectiveness of the study, of course. The protocol paper is published in BMJ Open, as you can see here. And we used a hybrid experimental design. And this looks like this. It is in fact a 3-arm study where we have a typical randomized control part with 2 arms, being the intervention group and the control group. But then we had a 3rd arm, and this is a comparison group. These are patients that are included or recruited in hospitals where no transition intervention is implemented. And the purpose of this design is that we try to exclude, or at least get an idea if there was a certain level of contamination. It could be that having the intervention in the center could have an influence on the control patients in the control arm as well. And with the comparison group, we could investigate this. We are currently finalizing the databases, so it's in the upcoming months that we know if the Stepstones intervention studied in people with congenital heart disease was effective or not. So today I cannot reveal any information on that yet, because the analyses are in process. But I can tell you something about the process evaluation. And indeed, in addition to the effectiveness study, we also conducted a process evaluation and an economic evaluation. And there we already have some information. The protocol paper on the process evaluation is, as you can see here, also published in BMJ Open. And this is how the process evaluation looks like. We have different components that we wanted to investigate in this: implementation, context, mechanism of impact, and the outcomes. And regarding the implementation, we looked specifically at the fidelity, adherence, the dose, the reach and acceptability of the intervention, also how the delivery is achieved, and how the implementation has been conducted. The sources for this kind of information are both quantitative and qualitative sources. Qualitative being observations, focus group interviews, individual interviews, all indicated in orange here. The quantitative information is coming from transition plans, enrollment forms, implementation forms, indicated in blue here. Then regarding the context, mechanisms of impact and the outcomes, we also had specific sources of information, again quantitative and qualitative information. What are the first data? What is the first information that I can show to you? The first paper that we published on this had to do with the reach. Who are the patients that we were able to recruit in the study, and do they differ from patients who did not consent to participate? And for this study, we also used both quantitative and qualitative information. And this is actually a first table that you could find in this article. We investigated statistically significant differences, but we focused more on the effect sizes because effect sizes are less vulnerable for the size of the sample. And we found in general there were small differences except for disease complexity and the primary diagnosis, the primary heart defect. There was a significant difference here in statistical terms, but also in terms of effect size. It was clear that people with a mild heart defect were less prone to consent to participate in the study than people with a complex heart disease. When we interviewed the patients, we learned that there were three main domains that explained if a patient wanted to participate or not. And that was, on one hand, altruistic reasons, personal reasons, and external reasons or external factors. And let's have a closer look at these. Regarding the altruistic reasons, people who signed up for this trial, they wanted to help other adolescents in the same situation, and they wanted to contribute to research and improved care. They just felt that it was the right thing to do to participate in a study like this. Regarding the personal reasons, we found that meeting others in the same situation and the educational objective were triggers for people to partake in the study. On the other hand, meeting others in the same situation was also a barrier for some people. Some people didn't want to meet other patients with similar conditions because it felt a bit awkward to them. And then other reasons that people say, well, I feel healthy, I don't see the need to partake in a transition program. And this explains why the mild heart defects were less prone to participate. And then finally, the external reasons. Here we see that parents can both be facilitators to participate, but also can be barriers. So the role of the parents in deciding if whether or not they would partake in the study, that was very critical. A second paper that we published in this respect pertained to the mechanisms of impact. And let's go back to the initial intervention. Remember, we had the 8 components and the 5 steps. Each component was evaluated based on the experiences of the adolescents and parents who partook in the study. And we also tried to understand why could the intervention work or why not? What is the mechanism of impact in this respect? When we have a look at the different components and how they are experienced, we can see that regarding the transition coordinator, people indicated that being seen as a unique person in a safe place and meeting in an equal caring relationship that gave them control over their condition. These were very important and highly valued aspects of the transition coordinator. On the other hand, they also indicated that there is even more need for individual tailoring the intervention. The intervention was individualized, but still patients indicate a higher need for this individual approach. Regarding the written person-centered transition plan, we asked the person before the first meeting to write a narrative, like who are you and what are your ambitions in life, and tell me about you and about you with your condition. And that was strange for a lot of people. You need to know that these people were 16 years of age at that time, and that was maybe a bit too young for this kind of abstract thinking. On the other hand, the goal setting that helped them to get motivated and it felt supportive. The information and education was positively appraised, and also the availability by telephone and the email. They knew that they could call or text the transition coordinators, and that gave a feeling of safety. Regarding the information about and contact with the adult clinic, patients really appreciated this because then they knew who they wanted or they would see once that they are transferred, and it already familiarized them with the adult care environment. Guidance of the parents, they trusted the transition coordinator and they knew that their child was in good hands. But at the other hand, they still had an ambiguous feeling about the change in the role that they had. Letting go their child, that's difficult for all parents and especially for people with a child with congenital heart disease in this case. Meeting with peers, like I already said, it is highly valued by several patients, but some people felt uncomfortable, it felt awkward, and for some it was a reason not to participate, and those who participated really needed to find their way. And then finally, the eventual transfer to adult care. They were well prepared and it was recognizable due to the transition program. But at the same time, and this was because we implemented this in a study context, in an investigational context, there was an asynchrony between the usual care, between how clinical practice is working and the study, the intervention program within the study. Then the mechanisms of impact. This is explained in this figure. And here we could see that the information and education that was provided really helped them in their development and in achieving the transitional goals that the patients had. The transfer to adult care, they felt control over their condition because everything was well prepared, and meeting the staff of the adult care was done on beforehand, so it was not an abrupt change for them. Getting to meet the peers and role models, this was positive for many patients, but we need to bear in mind for some people it felt uncomfortable, like I said before. But it clearly indicated that meeting peers made that they didn't feel alone, and that they knew that there were other people with similar conditions who went through it on beforehand, and they could learn from them. So they really could identify the role models during these adolescent days. The transition coordinator was really a person who was listening to them, approached them as a person, and they trusted the transition coordinator. It was kind of a skilled companion going with them through the transition. And then finally, the guidance of the parents. Also, the parents felt empowered, and once again, this is because they knew that they could trust the transition coordinator. Their child was in good hands. Right now, we are writing a paper on the fidelity of the implementation of the transition program. It is under review, so therefore it is too early to share these findings with you. Hopefully you can find this paper in the literature in the upcoming months. The Stepstones project to a large extent helped us or inspired us in the development of a global consensus statement. This is a consensus statement that was written by different professional entities and patient organizations in the area of congenital heart disease. It was stimulated and facilitated by the European Society of Cardiology, and this consensus statement is just published in the European Heart Journal. What is important in this statement is that there we explicitly indicated what is the process and the timing and components of transitional care. And as you can see here, it starts early enough at the age of 12 with the first introduction of transition. The implementation of intervention starts at the age of 14 with a regular assessment of the needs using the HEADS, with counseling and education, developing and working with the transition plan, and also working with the parents because their change in role is pivotal. At the age of 16, the peer contact and familiarization with the adult team is set up, and then the transfer is organized. It all depends on the local situation and the possibilities that the center has, but also the readiness for the transfer of patients. And therefore, we are talking about a range of transfer between 16 and 20. And then, of course, after the transfer, the continuity of care needs to be monitored because we know that a lot of people with congenital heart disease drop out of care after the transfer, and this has detrimental effects. So, these are the first experiences that we have with the Stepstones project. The first experiences were based on a study in congenital heart disease, but currently we are also doing a study in young persons with diabetes, and hopefully we can present the results in some years. Thank you very much for your attention.